Our first presenter is Dr. Samira Jabakhanji. She is a postdoctoral researcher in RCSI, University of Medicine and Health Sciences, in the School of Population Health, and also in Heidelberg University Medical Faculty Mannheim in the Center for Preventative Medicine and Digital Health. Samira is a postdoc researcher in these areas. She conducted her PhD in RCSI on the epidemiology of early childhood obesity and has been involved in various obesity-related studies. Additionally, Samira is currently working in relation to climate change and health and diabetes research in RCSI's Converge program. She is a founding member of the Obesity Cobweb and is currently the chair of the Cobweb network. So today, Samira's presentation will focus on the differences in measuring childhood obesity in health economic models. Over to you, Samira.
Thank you, Tara. I'm just going to share my slides here. I hope that you can all see them well. Should be in presentation mode now.
Yeah.
Great. So hi, everyone. Good morning, good afternoon, whichever time zone you're in. It's great to see such great interest and attendance to the webinar. My name is Samira Jabakhanji, and today I will be talking about differences in measuring childhood obesity in health economic models. To give you a little bit of background, when we look at obesity interventions, the childhood and early childhood in particular is of real interest because interventions at that age have a high potential to be very cost effective, simply because the effects of the interventions would be lasting for the remainder of the lives of these children. And when we want to study these effects, health economic modeling comes in as a really good decision support tool because it can actually assess the intervention and policy effects in relation to costs and cost savings. But when we did discuss this at various events within the Cobweb network, we actually acknowledged that there is a huge need to address various inadequacies in the research that is lying behind the health economic models that we're running in relation to data, the methodology, and how everything is documented. This is just really a snapshot of what we mean when we talk about simulation modeling. I'm not expecting you to go and read all of this in detail. It's just really to show you on the left-hand side at the top, a lot of data. Well, first we have research questions, of course, then a lot of data go into these models that come from various sources and contain various, well, measures of body mass index, for example, or other anthropometric measures, disease risk, and various socioeconomic factors, environmental factors, cost data, of course, that is all thrown into a simulation model to simplify here. And then we can use these findings to inform clinical practice and policy. And as I mentioned, one of the inputs that goes into these models is anthropometric data, for example, body mass index, which is what I'll be focusing on here today. We probably all are aware that BMI is not the ideal measure of body composition. There's obviously limitations in terms of it's not perfect in assessing body fat, for example, and lean mass. But at the same time, we also need to look at the advantages, which is that it's really easy to measure. It's cheap to measure. It's not invasive, which is in particular of importance when we talk about children here, because parents might be concerned about this a lot. And then also what comes in really handy is that we have a fairly long history of measuring weight and length or height data for children. And that means that when we look at the population level, because we have such a breadth of data there, it does give us a relatively good indication of overweight and obesity prevalence when we want to compare over time or between countries. So that means that because of the simplicity of the tool, cost effectiveness of how you measure it, and the comparability of it, it has been used widely internationally, and there is availability of many data in terms of body mass index. But We also need to acknowledge that there is subtle differences in terms of children versus adults. For adults, there's quite clearly defined cutoffs that are mostly used worldwide, which is overweight is defined as a BMI equal or higher to 25, but below 30, and obesity would be a BMI equal or higher than 30. Whereas for children, it looks more like this here on the right-hand side. As children gain in height, now these growth charts are from the Center for Disease Control. We see that actually the curves of BMI are supposed to dip a little bit before they increase. So children are supposed to have an increasing BMI as they grow older. So it's a bit more difficult to say what is too high. And now this is a very busy slide. You're not expected to read all of this. It's just really to give you an overview of how can we try and make sense of the different BMI values that we have. And there are different child growth criteria nationally and internationally. Here I'm only displaying the main ones that are being used internationally. And they would take BMI for a specific age and sex. And age, it could mean for a particular month in a child's life, or even like narrow it down to the day. So the age of children in days, and just classifies the various BMI values that children could have at this particular age and classifies them into different weight groups. And in the left column, you can see the different growth criteria that we see a lot in the literature, one being by the International Obesity Task Force. Then the World Health Organization has a growth standard for young children and the growth reference for older children and teenagers. There's the Centers for Disease Control growth charts, the UK90 growth charts, and a combination of UK90 and WHO for young children as well. And they differ hugely in terms of the age range they apply to, the populations and the sample sizes of the data that underlie these growth charts. So, of course, there were children from whom data were taken to construct these growth charts. And some of them were collected longitudinally, but most of them are actually cross-sectional data. And these were collected across different time periods. So some of them are a bit older than other growth references or growth criteria. And there are also subtle differences. For example, when we look at the WHO growth standard, these data were all taken from healthy breastfed children. So they're supposed to display the optimal healthy growth that is expected under ideal feeding and environmental conditions. Whereas most other growth criteria give you more of an average of the whole population of children, and not just those that are healthy and therefore considered to have optimal growth. Then also we see, for example, the UK90 provides separate growth criteria for premature children, but that is not necessarily the norm. So there are differences between these criteria, is what this slide is supposed to show. If you want to read more through the details, you can do so once you get the recording of the session, pause it there. So the questions that we were asking are, well, which criteria do studies apply when we look at health economic models? Which criteria should studies apply, and does it actually matter at all? So to get to my first question of which criteria do studies apply, we conducted a systematic review of health economic obesity models with the aim to identify methods and outcomes used for long-term modeling of obesity and implications for economic evaluations of obesity interventions. And when I say long-term, that means anything equal or longer than 20 years of modeling duration. We had a great team of people at Heidelberg University, RCSI, Deakin University, and our protocol has been registered, so you can look up the details there if you wish. We started in August 2022. Now we're near the end of data synthesis. Things always take longer than you think, as you may well know, to a huge part because we ended up including 80 papers. But today I'm only going to refer to the 27 studies that included children. So these were any health economic models that evaluated or assessed interventions in children. Just to give you a brief overview of the literature we found, when we look at the publication trends, we see that from 2016 onwards, there were more health economic models of obesity in children published. We see that most of them were published in the global north, with a huge chunk in Australia. We see many in the United States and the UK. There was one study from Mexico, but mostly otherwise Europe. We were actually quite surprised to see that a lot of the studies already started at an early age. So nearly 3/4 of studies included young children. And then we do see some that include school-aged children or teenagers. And what we were also very happy to see is that almost all of these studies modeled over a lifetime. The interventions that were included in the models were largely non-complex interventions, though that could be anything like, for example, a medical intervention would be considered non-complex. Most of the interventions were nutrition or other lifestyle interventions. There were a good few regulatory, so that could be anything like food taxes, for example. Some medical, one on childhood education, and then some hypothetical scenarios that did not actually study an actually implemented intervention, but just a scenario that they invented. Most of the models were Markov models, and now I'm not going to go into the details of any of this. It's just for those of you who are interested. And most of them used a societal perspective, and some actually provided both a healthcare system and a societal perspective, which we thought was good. And when we look at what data came from, well, the population data and disease data that were used were to a large part from census data or national statistics. Then we have cohort studies, cross-sectional studies, a good few administrative records, which include patient registry and patient records, some RCTs, some meta-analysis data. One study used big data, or they took the estimates from other modeling studies. And then when we look at the intervention effects, most of them came from observational studies, meta-analysis, or trials. So now to answer the actual question I displayed earlier, we were looking at how was obesity measured. Most of the studies used body mass index. A few actually provided both body mass index and weight as a measure of obesity. And when we look at which child growth criteria were used, when we look at the reporting of these papers, we found that unfortunately half of the papers do not specify which criterion was used. We do see that among those that specified this, a good few used the WHO growth standard, which makes sense because we have a lot of young children included. We see some using the CDC, the IOTF, the UK90, the NIH model of body mass change. Some used national criteria, and then actually one study used the adult criteria, and that study had included teenagers from the age of 15 years and onwards, and they would just use the adult BMI thresholds. So overall, we see that there is a difference in reporting in terms of national versus international criteria, and unfortunately, we see that half of the studies do not report any criterion, but generally, they do still mention that they studied the change in BMI or changes in BMI standard deviation or BMI Z scores, which indicates that actually they might have been using a criterion, but just not named it. And when we looked at the challenges that the authors of these papers were reporting, we do see that there seems to be a challenge in studying the very young age group because it is very complex to model BMI from birth to the age of 2 years. And also what the authors mentioned was that the original studies lying behind their models differ in quality, in representativeness, disease definition and diagnosis, study population, and well, also in BMI measurement. So there do seem to be difficulties here in conducting the health economic models because of the underlying data. Now, to get to the second question of which criteria should studies apply, when we look into the literature, we do see that there are subtle differences, but there is not really a consensus on, well, this is the perfect criterion that we should be looking at. For example, the WHO growth standard and growth reference, their curves tend to resemble those of healthy children a bit more than other criteria. When studies compared the different criteria among each other, they found that the WHO criteria were just slightly more likely to identify children that were at a higher cardiometabolic risk. And for those children that also later had overweight and obesity, they tended to be at least identified a little bit earlier than when other criteria were used. When we look at the IGF growth reference in comparison, it's great because it has such a long history, so it has been commonly used. You will see it in a lot of papers, but it's only applicable from the age of 2 years. And obviously, the WHO standard and growth reference do seem to offer some subtle advantages over the IOGF, but studies all conclude that more research is needed in which actually are the more accurate ones. And then also we need to differentiate between clinical and epidemiological criteria. So when we look at the WHO growth standard and growth reference, for example, the clinical criteria would be based on percentiles. And when we look at population studies, they're supposed to use standard deviation thresholds. And you can see here, I displayed in brackets the other metric that this translates to, and we just see that there is a small difference. So it's really important to say whether you used percentiles or standard deviations. And also we see that the standard deviation threshold is different for the growth standard and the growth reference. So for example, 2 standard deviations here means overweight using the growth standard and obesity using the growth reference. So we have to keep that in mind. And well, then lastly, does it matter at all which one we're using? Here I used data from Ireland because they show this quite nicely. In Ireland, we do see that there is a high prevalence of overweight and obesity among children. For instance, if we look here on the left-hand side, that's the colored lines, that's the growth curves in children, well, the BMI distribution actually in children up until the age of 5 years. And the shaded gray area in the background is the World Health Organization distribution of what healthy growth should look like. So you see that BMI tends to be a little bit higher in Ireland. Also, when we look at estimates, we see that the estimate of overall childhood obesity in Ireland is a lot higher than the global average. So we conducted longitudinal analysis of children's BMI in Ireland with the aim to investigate the prevalence of overweight and obesity in children aged 5 years and younger, and looking at differences in estimates based on various child growth criteria. There was a great team at RCSI, the Growing Up in Ireland study team, and families involved in the study, and the Irish Research Council supported the study. And just to give you a quick overview of the data, we used the Growing Up in Ireland infant cohort, includes more than 11,000 infants that were born in 2007, 2008, and are representative of children born in Ireland at the time. I think 1 in 7 births was included in that cohort, so that's quite a huge proportion. Families were interviewed when the children were 9 months, 3 years, and 5 years old, and we do see that we have quite a high response rate and valid measurements of BMI, and BMI was measured in a standardized way by trained interviewers. So that was a good way to look at comparable data over time. And when we look at the prevalence estimates that we get using different child growth criteria, we do see that there is a difference. Looking at the top line here, we see the WHO growth reference, which for boys at 3 years, where we see the highest prevalence, gives you nearly 50% prevalence. When we look at the orange lines, that's the IOGF growth reference, which is kind of giving you an estimate somewhere in the middle. And then the World Health Organization growth standard gives you the lowest prevalence. All seem to be identifying the highest prevalence at 3 years of age and kind of a drop afterwards. But you see that the actual prevalence estimate differs a lot, where the WHO growth reference says that nearly 1 in 2 children has overweight or obesity. The IOGF growth reference says that, well, it's roughly 1 in 4 children, and the growth standard says it's only 1 in 7 children. So we do see that does make a huge difference. And now that we actually have the different prevalence estimates, what we can do is compare this against international data. So here, internationally, data had been published using the World Health Organization gross reference. And we see that globally, the prevalence for the early childhood years was 21%. In developed countries, it was 33%, slightly higher, which makes sense. And we see that at 9 months and 3 years in Ireland, the prevalence is a lot higher than that. Whereas at 5 years, it's actually resembling the developed countries average a bit more. But so the idea here would be, because obviously now when we want to make these comparisons, we need the prevalence estimate from that same child growth criterion that you as researchers, I'm sure there's some of you in the audience today, ideally, if it's feasible, if it's practical for you, should both provide the IOTF and the WHO estimates, and maybe even some of the other international and national criteria, maybe do so in the appendices of your studies, just so that when other studies want to compare their prevalence estimates against yours, they can, or when several sources should be combined in a health economic model, that this can easily be done because the comparable data is available. So just to conclude, which criteria do studies apply? We saw that there's various national and international criteria, and unfortunately there is no consensus on a uniform criterion. Which criteria should studies apply? Well, difficult to say, but it's really important that you're being transparent and consistent in how you use them, and report them, ideally using epidemiological population health criteria, if you can. Otherwise, if it's clinical criteria, make sure you state this clearly. And does it matter at all? Yes, I hope that I was able to show you that. With this, I will end my slideshow. We will be taking questions at the end. And I thank you for your attention. Thank you.
Thank you very much, Samira, for a great presentation and for keeping within time, which is always good. Thank you. So finally, it is my pleasure to introduce our last speaker of today, Alfredo Mariani. So Alfredo is a senior health economist at the National Institute for Health and Care Excellence, or NICE. He has been involved with the technical development of NICE guidelines since 2020, first as a health economist at the Royal College of Physicians, and later he joined the NICE guidelines development team. His interest is in modelling outcomes of obesity, began during his internship with the Child Obesity Policy team at the Department of Health and Social Care. More recently, Alfredo has joined the technical team for the weight management NICE guideline, where he developed the NICE BMI model adapted from the prime time model. So today, Alfredo will focus in his presentation on modeling long-term obesity outcomes and weight regain trajectory. Over to you, Alfredo.
Thank you. Okay, good morning. With this presentation, we're gonna discuss the role of models when it comes to evaluate the cost effectiveness of intervention to reduce weight, and how the model can help us also to predict, for instance, weight regain trajectory. So first of all, this work comes from my experience working for the weight management guideline at NICE, and there were other health economists who worked with me at the guideline, Jeremy and Miao, who I believe are in this webinar. Hi, and we also received external support, particularly from Professor Peter Scarborough at the University of Oxford and the Nuffield Department of Population Health, who developed the prime time model that we adapted. So in terms of when we evaluate weight management intervention, we have a few challenges. First of all, the cost So the bulk of the costs usually occur at the beginning of an intervention, for instance, when you introduce a policy. But you expect, as we discussed today, also savings and other costs that could occur in the future. For instance, in the UK, there is a clear established association between BMI and social care. So if an intervention reduces the weight of a person, then you could expect some savings occurring later in adulthood. A second challenge is the fact that there is a clear time lag between exposure to an intervention and the health outcomes. This is because if a person, if an intervention is effective in reducing the weight for a person, then the majority of the benefits, which is a reduced risk of developing diseases and conditions associated with BMI, such as, for instance, diabetes, can be really appreciated only if you look at this person with a long time horizon, particularly a lifetime horizon. Therefore, particularly in trials where there is a short time horizon, like 12 months or 3 years, you cannot really appreciate these outcomes. And finally, most of the intervention, if not all, that are effective in reducing weight are actually accompanied by a weight regain. This is a natural phenomenon. And if the weight reduction is not maintained over time, of course, the effectiveness and the reduced risk of the diseases will not be important as you could expect. And this must be taken into account when estimating the cost effectiveness of this intervention. So let's look at an intervention that we looked at. This is a low-calorie total diet replacement intervention and was studied in a clinical trial called Droplet. So the goal is to evaluate whether this intervention is cost-effective, it's a cost-effective use of healthcare resources in the UK. And this is a randomized trial where half of the population receive this low-calorie total diet replacement intervention, and the other half receive best care, usual care. And we have different outcomes available, such as cost, kilograms lost, quality of life. So first of all, is this intervention effective? Well, if we look at the graph that you see here, which represent the weight change in the base care, in the usual care, blue, and in the intervention arm, which is the red dotted line, we see that intervention is clearly effective. Particularly at 6 months, there is a difference of 12 kilograms. So the people who receive this intervention lost weight. Though we can see already that there is a weight regain starting from 6 months, and we see that the pace is much faster in the intervention group compared to the usual care group. And also we observe a delayed effect, because if we should just use the 12-month results from this trial, they have self-reported AQ5D quality of life. There is a very small improvement in quality of life in the intervention group, 0.02. And if we had to use the NICE decision rule, which is to look at the ratio between the difference in cost and difference in quality of life, we will conclude that this intervention is not cost effective, because we just see a very small improvement in quality of life in these 12 months. So how can a model help in this scenario? So first of all, a statistical model allow us to estimate delayed benefits that occur over lifetime and cannot be captured in a clinical trial. The same can be said for the cost. With a model, we can incorporate costs that occur later, particularly if the intervention has weight maintenance support to avoid weight regain, or savings caused by a reduced need of healthcare and social care. And finally, we can use statistical model to attempt to predict long-term weight regain beyond the last follow-up available. So let's look how this can be done. So the most commonly used models are so-called BMI-based model, or BMI-based models. And the one that we use is called Primetime model. It was developed by the University of Oxford, and it works in the following way. So the input is change in kilograms. So what we saw in the clinical trial, how many kilograms people in the intervention group lost compared to the usual care. And the model translate this change in kilograms into a shift in BMI distribution, looking at how many people receive the intervention and how their BMI will change after these kilograms are lost. And this is the intermediate outcomes. The final outcomes, the long-term consequence, are change of disease prevalence, which are caused by a change of BMI. And all the model include all the diseases that are clearly connected with BMI, for instance, IHT, stroke, diabetes, and several types of cancer. And finally, the change of disease prevalence allow us to understand over a lifetime what's the difference and savings in healthcare cost, and how much quality of life is, how quality of life is increased due to the lower prevalence of diseases, and also to understand mortality. So in terms of estimating the risk of the diseases, the prime time model used a meta-analysis, a very large meta-analysis conducted by the prospective study collaboration. This is published in Lancet. And as you can see, it's a very large meta-analysis on around 1 million of adults, including several studies. And the purpose of this meta-analysis is to understand the relationship between an increase in BMI and the risk of developing a disease associated with BMI and mortality as well. The model assumes that BMI is a risk factor above 23 units. This is commonly done, although there are different numbers, for instance, reported by the WHO. That means that below 23, an increase of BMI, of course, does not increase your risk of any diseases, but above 23, an increase of BMI increase your risk of developing one of these diseases. And as you can see, there is an exponential increase in risk diseases. So this is particularly clear for instance, diabetes, which is in the graph in the right hand of the slide is the red curve. So you can see the diabetes is strongly associated with BMI, and this is what was found in this meta-analysis. But also this is true for any diseases. You can see this is true for IHT, which is the blue curve that you see below, and then all the types of cancer, although the association is less stronger. In terms of external validity, the model predicts that a person with a BMI of 35 units will have 7 times the risk of developing diabetes than someone with a BMI below 25. And this is in line with observational studies published by Public Health England, which is a former public health agency in England that looked at outcomes related with obesity in England. So external validity seems to be reflected and respected. So what about weight regain? So in most weight management intervention, weight loss is followed by a rapid regain, and we can see here in the figure on the right. So this is the same trial that we looked at before, but this time we have 3 years time horizon. This is the latest follow-up that was published, and you can see that weight regain continue even after 12 months, and you can see that there is an important weight regain. The curve is steeper, and you can see that the more time passes, the closer people who receive intervention are to the usual care. So the intervention is clearly losing their effectiveness over time. And this is actually something that is not surprising. It's something that has clear physiological causes. For instance, it is reported that weight loss is associated with an increased appetite and a decreased satiety. So it's quite common that after a rapid weight loss, there is some kind of weight regain. The important thing is to understand how this weight regain is strong and to try to predict over time. Weight regain is dangerous because people sometimes can gain more than they losses. They lost this is reported, or they can gain a higher percentage of fat mass than they lost. So it's important to take into account weight regain to understand whether an intervention is harmful and cost effective. So traditionally, health economic evaluation have incorporated weight regain because they favor lifetime horizon. That's definitely what we do on NICE2. And traditionally, different assumptions have been used. These are from a paper looking at different assumptions. It's a systematic review of economic evaluation, and that incorporated weight regain and look at the assumptions that were used in this economic evaluation. So the most common use are the following 3. So the most optimistic, the best and most optimistic pessimistic is the assumption that the weight loss is maintained over a lifetime, and you can see that this is quite optimistic and definitely does not reflect what we saw before in a 3 years follow-up from the trial. And this assumption obviously tends to overestimate the cost effectiveness of an intervention. Another very extreme assumption, which is this time pessimistic, is to assume that the weight loss is regained immediately after our last follow-up available. Again, this is probably unrealistic as the first one and tends to underestimate cost effectiveness of the intervention. A middle ground that is usually, I think the most commonly used in economic evaluation, is to assume that weight regain occurs, and at a certain point, people that receive intervention will reach the same weight of the people in the usual care in the comparator arm over a time of 5 years, for instance, and then the assumption is that this weight is regained using through a linear fashion. This is another assumption. It is the most commonly used because it's the middle ground between the two. So in our case, for instance, we have this curve represent what you observe looking at different low-calorie diet interventions. So this is observed weight change over time after the intervention is given to people. So if you were to use the more pessimistic weight regain, we will have something like that. And if we were to use the more optimistic full maintenance, we will have this red curve here, and the middle ground will look like something like this. However, if data is available, is it possible for us to make better prediction and to understand better how weight regain is behave over time? And this is what we attempt to do. And we use 5-year academic in confidence IPT data from direct trial, which is another trial on low-calorie diet intervention, and we try to understand whether a parametric curve could be fit to the data set. And we found that the best fit is a curve called a Weibull curve. It's a 2-parameter Weibull curve, and it looks something like this. So this is how this is a parametric curve that better reflects what we have, the data we have. And therefore, we incorporate this into the model instead of the other assumption. And compared to the graph we had before, the Weibull curve looks something like this, which even visually looks something like more natural and organic than the other assumption that we have. This is very important because, as I said, we said at the beginning too, there is a delayed effect. So a lot of the outcome of weight loss tends to occur later in life. Therefore, the assumption of weight regain is quite pivotal. Like using an assumption instead of the other actually can change the conclusion of a cost-effectiveness analysis. So it's very important to try to use a curve, a weight regain trajectory that better reflects what we have in terms of data and what we expect to occur in the natural world. So the conclusion of this presentation is that, as we saw, there are several challenges when we need to estimate the cost effectiveness of a weight management intervention. And the first challenge is that there is a clear delay effect. So cost savings and benefits tend to occur much later in life. That it's also hard to estimate, to understand how weight regain will behave and to predict a weight regain trajectory, because it's often hard to capture when a time horizon is short in a clinical trial. A statistical model can help us with the following. First, it allows us with a BMI-based model to estimate benefits and also costs that occur later and savings as well. And also it allows us to predict weight regain if we had enough data, of course, using parametric curves. However, as all statistical models, they tend to have some significant limitations. First of all, any models, particularly Markov model, cohort model, like primetime model, capture trends with the aggregate population, but they may vary a lot from individual experience. For instance, the weight regain varies a lot across individuals. There are individuals that report that diet intervention are particularly bad because they regain weight immediately. Other people can maintain the weight loss for a longer time. So it is hard to use such a model to predict the weight regain of a single individual. But what the model attempts to do is to predict the weight regain, the average weight regain of the aggregate population. So that's why we use a model that is based on a very large meta-analysis, such as the one in Lancet, for instance. And the same is true for BMI. We discussed again in Samira's presentation the issues that we have with BMI and as a predicting factor of diseases. For instance, sometimes BMI is associated with muscle mass, and of course, muscle mass is not a risk factor of any diseases. So again, a model such the prime time model cannot really be used to estimate the risk in a particular individual, but again, it's very useful to understand the risk that the average risk that have an aggregate population, like for instance, people in England or people in the UK, etc. This is the end of my presentation. Thank you very much. I look forward to hearing any question you may have. Thank you.
Thank you very much, Alfredo, for a very insightful presentation. I feel like I've learned quite a lot from that. So thank you again. So I would like to invite all of our presenters for a Q&A session. So I'm just going to spotlight everybody on the screen. So we'll open the floor to discussion. So if anybody has a question, please feel free to either unmute yourself and ask the question or type it in the Q&A or the chat function.
Hi, good morning or good afternoon, everyone. Can I just ask a quick question? My name is Luis Andrade. I'm a research fellow in the University of Birmingham, and I work in some projects that aim to increase physical activity among children. So my question actually is just a simple question, but I don't know if I missed something. But does the length of intervention might affect the time to weight regain in the graph that you showed? So I was just wondering actually how that might affect. Thank you.
Yeah, so this kind of intervention usually have a weight maintenance support. So you will have, for instance, for low-calorie diet intervention, people receive this diet for a while and then they start to eat again normally after. But then the most effective intervention usually have some kind of support where weight is systematically measured, and then if there is a rapid weight regain, sometimes there is a rescue plan where people start again the diet in order to avoid the weight regain. So yeah, definitely the this kind of component is very important, this kind of intervention. Also, there is, I believe there is also a little bit of lack of research on this. Like, it's something extremely important because it really matters for in the end. And there is a little bit of lack of research on what is the best, for instance, maintenance, weight maintenance support strategy, what people should receive, and how, you know, to avoid relapses and to avoid weight regain. But usually this kind of studies try to have and incorporate some kind of strategy to follow the individuals for a longer time.
Thank you.
Thank you. Any other questions from the audience? I see Sarah O'Brien has her hand up first. So Sarah, would you like to unmute yourself and ask the question?
Yeah, hi, really good and really interesting presentations, and quite raise a lot of questions, I suppose. Very challenging area. I suppose I'm not sure whether it's Alfredo or Samira now that will have some perspective on this, but just thinking of what you were saying there, Alfredo, about I suppose the weight regain trajectory that's very evident in interventions where it's kind of diet meal replacement, or there's a very strong focus on achieving weight loss over a period of time. And then Samira, what you were talking about, that kind of early childhood intervention, and if we take the understanding that obesity is a lifelong condition that needs to be managed over time, I suppose I'm just trying to figure out how we use that kind of these economic modelling for interventions that might happen at a point in time early in a child's life, but may not be maintained or sustained or any further intervention at a later point.
Alfredo, do you want to go first, or?
You should go ahead if you.
Okay, well, now, first, I should say that our results from the systematic review, like we're just about getting, like, looking into the actual effects or the actual outcomes of the interventions, and kind of looking into each individual one and which intervention led to what and which intervention did what, essentially. But generally, when we talk about early childhood, a lot of the interventions we would be seeing are more on the preventative side. So hopefully a lot of the children that would benefit from the intervention would actually not have overweight or obesity at the time that, for instance, the policy starts affecting them. Obviously, this is not always the case, and I think there is a case for, like, children who have excess weight at a very young age to be managed clinically. Otherwise, we very often talk about broader interventions like population, like school-based interventions, for example. But again, they would be more on the preventive side. Does that answer your question?
Yeah, so I suppose what I'm hearing is that the case is for those wider population level rather than individual level interventions at kind of settings, whether it's schools, communities, regulation.
I would say that, like, we totally need both, but for children in particular, I think that individual treatment, if they need it, is very important. And I mean, we had one medical intervention in the set of interventions, so that would probably be looking at an actual kind of treatment. But what our systematic review covers is just what has been published in the literature, and I suppose that there is a lot more research conducted in terms of prevention for children. So this is by no means saying that there is no need for treatment in childhood. It's very important.
Oh yes, absolutely. I agree. I suppose maybe my question was maybe framed a little bit awkwardly. I suppose it was more that, you know, I suppose sometimes those interventions are put in, those population or settings based interventions are put in at a point in time in the child's life, but they may not continue throughout the child's life.
Yeah, and this is probably something where, like, it's a really important point. We will look at that a bit more now in the kind of last phase of analyzing our data. Thanks, that is actually a really important point to look into. Which type of intervention was maintained for how long? Yeah, thank you.
Thanks.
So I see Fiona also has her hand raised. Would you like to mute yourself and ask a question, Fiona?
Yeah, so I put my question into the chat as well, but I just wanted to ask about the DRGs and whether or not there's any economic models that look at the patient pathway in the treatment of obesity, so or the number of interventions that follow the patient journey, just so that you can identify how the healthcare services are used by individuals who are living with obesity. In Ireland, we don't have a unique patient identifier, so it's not really something that we can do when we look at healthcare price costing. So I'm just wondering if there's any other literature out there that would describe that.
I'm not sure whether it was a question for me or someone else, maybe Alfredo, but I think it would be possible. I'm not too familiar with the literature on it, to be honest, but it definitely sounds interesting. Yeah, I think could be possible. But I think that you would also need kind of these micro costing strategies, because other way you would get back to DRGs being the, at the end. kind of the end measure of costs. And it's a shame that they don't capture differences in BMI. I'm sure there's a lot of other things they could also capture differences in, but it would certainly be interesting to kind of compare the average DRG and then run a micro-costing strategy, and then kind of seeing how the cost varies for diseases that are typically associated with increased BMI, like diabetes, for example. And also just to look at pathways, like you say, I think it would be very interesting, but I'm not too familiar with the literature myself. I don't know if Alfredo or Samira, you have any other thoughts?
No, I'm also not aware of this kind of models. I usually the most commonly used models are Markov model, simpler model, where you look at a cohort and you don't look at single pathway. Although I'm sure there are, well, there were with Samira some kind of more individual simulation models, and I guess they both have their advantages and disadvantages. Usually cohort model, like the one we use at NICE, is simpler, easier for the stakeholders to understand, and also kind of like reflect enough the changes of healthcare use and disease prevalence in the population, which is what we are interested in when we assess the cost effectiveness on an intervention. But of course, it doesn't capture individual pathway and what happens to the people.
Yeah, just to add to this, now I don't recall all the details, of course, of what we found in the review, but from what I do recall is that if there were any individual pathways included in the models, there weren't many. So the majority of the studies we found were, yeah, just looking at the population level.
Okay, thank you.
Any other questions from the audience? Okay, I see a question that's come in the Q&A there from Amelia. So Amelia wants to know, is there any data on if there's an interplay between socioeconomic status and effect of obesity interventions on future direct costs and or possible indirect costs? Does anybody want to take that question?
I can try, but I'm not too expert on this. But we did a work on inequality. Jeremy particularly work on that, and the effect of inequality on, for instance, the effectiveness of the intervention. And we found like some quite interesting outcomes. For instance, I'm not too expert, but there is a clear differences in people who have access to obesity intervention based on socioeconomic and there people live, and also the effectiveness of intervention is associated with socioeconomic characteristic as well, which could be an issue because you don't want to increase health inequality through this intervention. You want to increase health and also reduce health inequality if possible. And we also know that obesity is shows a clear gradient, shows a very clear socioeconomic gradient. So usually, if I'm not totally wrong, I hope Jeremy in the call can help me. I think since obesity usually is more prevalent in people who have a low socioeconomic, this intervention tend to be given more to people with a low socioeconomic status, because they are the ones that are targeted by the healthcare service if their BMI is above 30. But then there is also a rate of completion that is different. So people with a higher economic status who receive intervention are more likely to succeed and lose weight, and people who are lower are less likely to succeed, and therefore there are conflicting outcomes. But this intervention usually tend to reduce health inequality because they're given to people who have a lower socioeconomic status.
Maybe I can add to this from what we found in the systematic review. It was actually mentioned in the limitations of studies quite frequently that they were not able to assess kind of that the difference, that kind of distributional equity aspect in terms of differential cost effectiveness or health economic outcomes in general by socioeconomic status. And they did acknowledge that sometimes, like, I think it really depends on which type of intervention we're talking about, because some interventions would require individuals to pay some money up front to kind of buy into the interventions. So for some people, there might be increased costs, at least at the beginning, that they have to pay out of their own pockets. And in that case, that just means it lowers the accessibility for people in lower income groups. And there were a good few examples of where there was that risk of not everyone would be reached in the same way with the intervention. And then obviously that has different implications on health economic outcomes. But then, as you were saying, after sometimes it might be the other way around. But we do see that a good few studies mentioned that there is a need to study this more.
Great, thank you very much. Have we any further questions from our attendees? Okay, while everybody gathers their thoughts, I have a quick question for Christina. So in your presentation, you highlighted how basically the variation by using different models in estimating cost for cost effectiveness. And I'm just wondering, in your opinion, do you think that some of the cost effectiveness analyses have ended up with possibly incorrect results because of this?
Thanks for the question. I think it's hard to say, right? It's impossible to say whether it's wrong without doing the analysis again. But I definitely don't think it's unlikely, and I think it goes for all these talks that there are, different ways of estimating different aspects of cost effectiveness models, and how you do it can influence the results. Yeah, so I would say that in the future, kind of researchers should be think more carefully perhaps about uncertainty, and think about uncertainty maybe also more of as a sensitivity analysis rather than only incorporating uncertainty. And I'm sure some also do this, but yeah, just to be aware that the cost can be very different, and I think it can give different conclusions, sometimes at least, obviously depending on how close it is to being cost effective. Yeah.
Thank you. Okay, I also have a question for Samira, if it's okay, while our attendees gather their thoughts further. So Samira, in your presentation, you've highlighted basically that BMI is not technically like the ideal measure for estimating body composition in young adults and children. So would you suggest that we stop using this measure altogether and replace it with a different measure, or like what are your thoughts on this? Because I mean, you've highlighted quite a distinct variation among all of the different criteria that are out there.
Thanks, Gintara. Yeah, that is a good question, and it's one that's being brought up again and again in discussion rounds. And I think it's really important to think about this and to advance how we measure obesity, both in research and clinically. I think, first of all, there is this distinction between clinical measures where, physicians, obviously, they should not only restrict themselves to measuring weight and height, but they should go beyond this and to see, like, to get back to the individual pathways, to look at individual patient tracks. I think it's really important to look at other measures of body composition as well, and to see, is there a change in lean percentage of lean mass, for example. But then when we look at the population level, and when we look at studies that try to capture what is going on in a country, I think their BMI does give us the big advantage of it's simply been used over such a long time. So it's just this one measure that is, in a way, comparable over time within the same country. It's also comparable between countries, or to the international average, or what I was showing, the average within developed countries or the global north, or whichever high income groups. You could kind of show the difference in different population groups. And this will not give you the exact right estimates for any individual within that group, but it will give you an average. And I think when we're trying to show the effectiveness of an intervention, and especially when we're not looking at like a smaller individualized treatment intervention, but we look at something that we are hoping to spread to the whole country, then it's very, very useful to use BMI and to be able to show how this performs in comparison to previous interventions. And so to me, it's really important to keep on using this and to be adding to it. So I think ideally someone running an intervention study now should be measuring BMI in a standardized way, because we also know that self-reported weight and height can be inaccurate, but to be measuring it in a standardized way and to add different measures. So maybe to add percentage of body fat and body composition, to be thinking about waist circumference, and maybe adding these measures and running the same analysis using the different measures, which, like, once you've set up your model, it should actually not be too difficult to just be running it a few different times using a different outcome measure. So over time, this will build the evidence, I think, that we need and that we currently still don't have for other measures of body composition.
Thank you very much, Samira. Any final questions, remarks, comments? Okay, well, I guess on that note, we will close off our webinar. So I just want to thank everybody for attending today's Obesity Cobweb webinar, and I hope that a lot of you or all of you found this webinar useful and that you've gained some insight into the health economic measures and perspectives of obesity across different populations from our three presenters. We are delighted to let you know that we will be hosting another webinar in the coming months. So do please keep an eye out for upcoming announcements from the Obesity Cobweb Network. So I'm here just sharing some of the contact information. So if you do want to contact us, please feel free to email us. And below, we also have a website, which you can reach out to us via that as well. So finally, on behalf of the Obesity Cobweb Network, I'd like to thank all of our speakers for their insightful presentations, and our Cobweb members who have been working in the background and in organising this webinar. And finally, if you would like to be involved in the next webinar, or if you'd like to find out more about our network, please use the shared information and get in touch. Don't be shy, we are friendly. And this webinar is officially finished, and I thank you all for attending.